And to get to the heart of the matter, tonight's conversation around access to family planning services. To take us through this conversation is none other than Dr. Clive Ogallo, who is the Programs Manager, Reproductive Health Network, Kenya. Karibu sana. Thank you for your time. Yeah. So the latest report indicates that 62%, that's where we are when it comes to, use of family planning. Yeah. From what is your take in regard to this particular number?
Okay, thank you so much, Regina. According to the KDHS 2022, that's the Kenya Demographic Health Survey, it shows that the contraceptive prevalence rate is at 62%, which is quite an improvement from 2 years ago, because it was 58% 2 years ago. So we've made drastic improvement, but then we are not yet there. Yeah, we need to do more so that at least we scale up the service delivery and then the uptake of family planning. Mm-hmm. Yeah.
Dr. then what, we have emerging modern ways of family planning, but 62, as you've said, yes, we still are to get to the optimum. Yeah. What is holding us back from taking up, family planning?
Yeah, so there are a number of challenges that holds people back. So one is preference. The people who prefer the natural methods, and then the others who want the modern, what we call the artificial methods. So when you talk about the 62%, then it combines, but then we focus more on the artificial, because the artificial we can measure, whereas the natural methods are not able to measure who is using the natural methods or not. Then the challenges that come, one, it could be the cost. There's a cost involvement in contraceptive utilization, so someone has to pay for it. But then of course we've been lucky that the government provides free services, but then not everyone would be able to access government services, because research shows that most Kenyans prefer going to private facilities where they have to pay for a service. So cost is a challenge, but also information. Most people don't have sufficient information about contraceptives. Then that affects the consumption and even the uptake. Then the other challenge there, we also have cultural barriers. Then we have culture that believe that they're not supposed to use family planning. And then even religious reasons also attribute to low family planning uptake generally. Mm-hmm. Yeah.
Now, looking at this particular report also now, it has also highlighted the areas like the counties of Mandera, Wajir, Marsabit, Garissa, lowest use of modern methods of contraception, while we have the highest unmet need, for family planning, very prevalent in Marsabit, Tana River, West Pokot, Samburu, Siaya, and Isiolo. What is so unique about, especially that, and this is not just contraceptives, just family planning, these counties unmet need? Why? What is so unique about this? Marsabit, Tana River, West Pokot, Samburu, Siaya, and Isiolo. What could be the issue?
So basically, unmet need is where someone wants to use a contraceptive method, yes, but then they are not able to use it for one reason or the other. And then the counties that you've mentioned, they are statistics, like even if you talk about teenage pregnancy, they're the same counties that have high levels of teenage pregnancy. So one, it's still the same things about information, access, culture, and then the health-seeking behaviors, because we have counties where it takes someone a lot of time before they decide to go to a health facility for a service. So it's a myriad of factors that influence why County A does better than County B. But basically, it's usually the health-seeking behaviors, the health service delivery mechanisms, and then the NGOs and civil society that are in those counties. Sometimes you find that access, so for instance, Samburu, by the time they get a service, the knowledge, the information, the expertise, the health workers, even preference of going to work in Samburu and all those factors. So it really contributes to the uptake of family planning or even the shortages that come with it.
Mm-hmm. Yeah. Now, access brings in access, information, and cost. Yeah, but then even looking at this particular report, when I look at the report, it talks about women.
Yeah.
I have not seen anywhere, where men have been, yes, I know they were part of the survey, but men are conspicuously missing when it comes to matters of family planning. Yeah. Why?
Yeah, okay, of course, male involvement has been a challenge in most of the health services. One, even antenatal care, family planning, and even other health-seeking behaviors. So then, why? Because the reasons are like, we have a wide range of reasons. One of them is that even in terms of the services that men get in terms of contraceptives, currently we only have two. That is vasectomy and then the use of condoms. So then if someone doesn't want to go for vasectomy, then they have very limited options left. Yeah. So but then they're supposed to support, we are supposed to support our counterparts in terms of accessing services. One, you can accompany your partner or your spouse. You can discuss on the methods in terms of side effects, suitability. You can also provide support in terms of finances, transport to the facility, pay for the service. You can also provide that social support, encouraging someone in case there are side effects that come with the family planning. You become supportive to the partner. At least you understand that the contraceptives or the family planning methods have some side effects that we will expect over time. So being supportive, that's what we call the social aspect of it, helps someone feel that they are cared for. So that will definitely help in increasing uptake. Yes.
I want to be the devil's advocate in this. You've said it's because men have limited options when it comes to, contraceptives. But then, even with the limited options, a majority of them leave family planning, use of contraceptives to the women folk. Yes. So what is an organization that, like yours, Reproductive Health Network Kenya, doing to rope in men in this conversation around family planning?
Yeah, we've done, as RHNK, we've done several things. One, we have programs that support male involvement, where we identify male champions. Male champions are people who have supported their partners to access family planning. So then we get the male champions to advocate for family planning use. We've also used religious leaders who are mostly opinion leaders in the community. So then they're able to talk about family planning and the need for male involvement in family planning use. Then we've also provided information to the males so that at least they're able to know that family planning is a way, because of course economic situations, you need to have quality. The children need to have quality life. So then when they do the spacing, it helps a lot. So we've done quite a bit. We also have conference that we hold every year in June. This year we're going to be in Kwale from 20th to 22nd. It's about localization of global commitments. So global commitments are commitments that have been made globally, but then we want to bring them down to our country, Kenya. So at least we scale up the CPR that we talked about, the prevalence rates go up, then we have zero unmet need, even the maternal death. It's a whole set of issues of reproductive health. So we discuss, we get experts, we get the government officials, policymakers to discuss and see how we can domesticate or how we can localize some of the global commitments made by the UN, made by in the Maputo conference, the ICPD of 2025 that was made like 25 years ago. So how do we achieve some of these things by involving the people concerned? Yes.
Now, talking about inclusivity also, there are a lot of stereotypes around the use of family planning. Let's unpack the issue of family planning from that aspect, because so much has been said that is very misleading.
One of the challenges that affects family planning consumption is what we call the myths and misconceptions. So myths and misconceptions are false beliefs that someone will say that when I use a family planning method, this is what happens to me. But then they are not proven, they're not scientifically proven that it actually happens. So one, it's meant to discourage the use of contraceptives knowingly or unknowingly. So one of the things that we do is to ensure that we demystify the myths that come with family planning.
For instance, there's the use of the hormonal pill. Actually, either it is said it lowers libido as well as the user gains, some weight when they're using it. Yeah. As a doctor, tell us, is it?
Yes, so you see the hormonal family planning methods contain the normal female hormones. We have progesterone and then estrogen. So then when you get them, side effects vary from one person to the other. So it's not a universal fact that all family planning methods or everyone will get maybe increased weight or decreased libido. There are client-specific side effects that come because of the hormonal aspect. But then these are things that can be managed. When you go to a provider, they can manage in case maybe you've gained weight. And again, we've got clients who report weight gain. But then if you look at the baseline weight at the time of initiating the method, and then the weight at the time of the complaint, you find that there's absolutely no weight gain. Actually, some have lost. But because it's a myth, or it's a belief, then someone will say, I gained weight. But then there are also those ones who actually gain weight. But then so you look at what the amount of weight gain, is it bearable or not bearable?
So it is individual.
It's individual.
Now, there's also the controversial conversation around, men, going for vasectomy.
Yes.
And we posed a question to our viewers tonight and asked them their preferred method of family planning. And the men are saying they can never undergo a vasectomy. From a doctor's perspective, within the Kenyan landscape, is this something that you're likely to see gain traction, or is it just there because it's a modern, form of family planning?
Well, comparatively, 10 years ago and now, we've had increase in vasectomy uptake, actually not just in Kenya, but even in East Africa. In Uganda, for instance, there's quite high uptake of vasectomy in a place called Mbarara. So there's an increased uptake. So not all will be against vasectomy, but then others would actually prefer vasectomy because, one, it gives you some peace of mind because you're sure if you're done with your family size, you're done, and you'll not get any complications that comes thereafter. So for men, like I said, we have two options, vasectomy and then the condoms. So the uptake is increasing, but it's not yet where it's supposed to be, but at least the uptake has seen an increase trend. Yeah.
Now, what then would constitute, before we look at what our viewers are saying still online, what would constitute, an ideal form of family planning?
Well, like I said, family planning is individual based. So then what we do as providers is to give information, and then you do an assessment of the client. Then they're able to make a choice based on the side effects, the information, the advantages, the disadvantages, and all that come with family planning. So it's basically giving information, then a client is able to make an informed decision about which method would suit them, also based on other needs, because we also have eligibility criteria of what suits a particular person. Maybe if they have coexisting, maybe comorbidities, they have some complications that will maybe make them not use certain methods. So it's really an individual, and it's not up to a doctor or a nurse or a midwife to prescribe a method to a client. It's based on what will suit a particular client at a particular time. So it's really about giving the information and packaging the methods, the side effects, the advantages, the disadvantages, and even demystifying some of the myths that come with contraceptive use.
Now, Daktari, as I'm trying to just rope together the feedback that we are getting on our social media platforms. So what is out there? Give us, just paint a picture of, the local family planning landscape in the country. What options are out there?
So currently we have the hormonal family planning methods and then the non-hormonal. Yes. So under hormonal we have the Depo-Provera, which according to KDHS it's the most popular. It's at 20%. Depo-Provera is the 3-month injectable, where we have the self-administered, which is called Cyanapres, which actually even as RHN we've promoted the use of Cyanapres because it's self-administered. You don't have to go to a provider to be injected. So it's at 20%. Then we have the hormonal implants, which we have 3-year implant and then 5-year implant. That stands at around 17%. Then we have the pills. The pills are also hormonal in nature. They come distant third. But then we also have other methods like the permanent methods, tubal ligation for female, and then vasectomy for
men.
Yes.
Now, quite interesting. I have a response here on actually in my inbox. Person has said P2. Now, we all know that, well, tell us, you're the doctor. They say that their preferred method is using P2.
Well, P2 is...
and I'm sure that's not the correct use of it's an emergency.
P2, like they would say, it's an emergency contraceptive pill. So, emergencies don't happen all the time. So that means you're supposed to use P2 once, actually, maybe once in 3 months. You're not supposed to use more than twice. So in case someone uses P2 most times, then at some point it fails, because like P2 is an hormonal method as well. So at some point it fails. And then even though sometimes you may use a pill when you're not in your unsafe days, for instance, and then you'll be loading your body with hormones when actually you don't need it. Okay. Yes.
So that is basically misuse of the pill.
It's actually one of the most misused, because we tend to create emergencies when we don't actually have emergencies. So that means you'll use an emergency pill when you could actually use another method which is more short-term or even long-term in nature.
Yes. And on that point where we create emergencies where they're not. Well, we need to speak sports. We have been speaking to none other than Dr. Clive Ogallo, the programs manager at Reproductive Health Network Kenya, and has also informed us of having a conference that brings about everybody on board when you talk about matters of family planning. We take a quick breather. Sports is up next.